So as people are streaming in, I want to take a minute to set up all the tech here and welcome everybody to the event. And then I'll go back to the slideshow in a second, just to give you a bit more background. My name is Bhadelia. I'm an infectious diseases physician and associate professor at the Boston University School of Medicine and the founding director of the Center of Emerging Infectious Diseases Policy and Research. So before I set up the slides and tell you a bit more about the organization, the structure of the event is going to be just an intro followed by about 10-minute remarks from each of the presenters, and then we'll take question and answers. And if you have questions, you can look at the bottom. There's a Q&A section in the Zoom invite, and so you're able to put in your questions there, and we'll be able to share that with the presenters. So with that, I want to welcome everybody to the first and launch event for the BU Center for Emerging Infectious Diseases Policy and Research. And, you know, gratefully, this is on a topic that I know it matters to many of you who are attending, to all our presenters, is close to all of our hearts. And it's not only meaningful for me that we're starting with this topic, but it's also meaningful for me that we're starting with these presenters who I've known, you know, for years in some cases, and I know have been working on topics of global equity in healthcare for a long period of time. So before we start, I want to tell you a little bit more about the Boston University Center for Emerging Infectious Diseases Policy and Research. As you know, we launched really just a week ago at this point. And a huge goal of what the center does is to improve societal resilience against emerging and epidemic threats. And we're doing that through research, through training, and through advocacy. And the events, such as the one we're going to have today, that we're likely to have throughout the rest of the year, are meant to bring these issues to forefront, to make those connections, to make us question the deeper conversations that can't be had in headlines and can't be had in 20-minute, radio or TV skits. And so this is a little bit more about us. You're able to reach us and find out a little bit more about the research that our faculty are doing, as well as the work that we're doing both nationally and locally on capacity strengthening, I should say, rather than building, as well as community engagement. So what are we going to talk about today? Global vaccine equity, very timely. As you may have heard today, President Biden made an announcement. The United States will be committing about 500 million additional doses that they will purchase from Pfizer to help with global vaccine inequity. And what are we talking about? If you look at this figure from the New York Times, which is taken from Our World in Data, the disparities in where the vaccines, COVID-19 vaccines currently are, is immense. And, Director General Tedros said that this implies that we're not just leading towards a vaccine apartheid, but we are currently in a vaccine apartheid. The longer the COVID-19 pandemic goes on, the longer our combined recovery lags behind. And beyond that, when you just look at COVID-19 pandemic by numbers, we scratch the surface when we talk about 174 million cases or the 3.76 million deaths, which, by the way, are both thought to be underestimate. The real number is thought to be about 2 or 3 times higher than that. And that loss includes the loss of healthcare workers that are holding up healthcare system across the world and helping protect us not just through everyday endemic diseases, but also potential new diseases that might arise on the and we may be too overwhelmed to pick up. It's also pushed about 95 million people into extreme poverty, additional 95 million, an additional 130 million into brink of starvation, is delayed routine vaccination to 13.5 million, and has left us undone decades of work on bringing under control things like the tuberculosis campaigns, as well as other emerging and endemic infectious diseases campaigns. It's left about 2.54 billion children out of school, which has pushed girl children out of school, which has put them at higher risk of entering child marriages. And overall, that inequity, is not just affecting resource-limited countries, it's affecting all of us globally, because the International Chamber of Commerce says that if we cannot achieve that, we're likely to see about up to $3 trillion in losses to the world economy. And for these important topics, I cannot think of 3 better people to talk about the important aspects of this problem. And I want to
take the time to introduce all of them and how they touch my life over the last decade or so. So to start with, Dr. Joia Mukherjee, who is a professor of medicine, the Division of Global Health Equity at the Department of Medicine and Brigham and Women's Hospital. She's also the Chief Medical Officer at Partners in Health. Majority of Dr. Mukherjee's work has been on focusing on the provision of health as a human right, in working on design, implementation, and evaluation of comprehensive healthcare in resource-limited settings. Since 2000, as I mentioned, she's served as the Chief Medical Officer of Partners in Health, a nonprofit medical organization that supports on reducing global health disparities. She provides strategic guidance on implementation of their clinical programs worldwide and has served as a consultant for WHO and Ministries of Health. She's also on the board of Village Health Works in Burundi and Muso in Mali. And she advises grassroots organizations throughout. She's also my North Star when it comes to health equity. I look to Joia to tell me, if we're aiming due north when we look at global health equity. We are also joined by Dr. Rajeev Venkayya, who's the president of Global Vaccines Business Unit at Takeda Pharmaceuticals. He leads a vertically integrated business developing vaccines for dengue and norovirus and Zika. Dr. Venkayya also serves as the independent member on the board of Coalition for Epidemic Preparedness and Innovations and International AIDS Vaccine Initiative, and is a member of the Council of Foreign Affairs. No better person to speak on these remarks because CEPI, as you know, has been part of the COVAX utility and the COVAX efforts to try to get vaccines everywhere. Prior to this, he worked as a director of vaccine delivery at Bill and Melinda Gates Foundation's Global Health Program, and has served as a representative on the board of Gavi and Vaccine Alliance.
Prior to his work with the Gates Foundation, Dr. Venkayya was also a special assistant to the president and senior director of biodefense at the White House, where he led biodefense policy and implementation, including the National Strategy for Pandemic Influenza.
And then last but not least, Dr. James Lawler, who's the associate professor in the Department of Medicine at University of Nebraska. And he is the executive director of international programs and innovation at the Global Health Security Center at University of Nebraska. Prior to his time at UNMC, he was actually an active military member. He was part of the military career that he's worked on to build global resilience worldwide when it comes to emerging infectious diseases capacity. And he was served as a Navy commander and was the chief of clinical biodefense research at Navy Medical Research Center in Fort Detrick. So the way that Dr. Lawler and I met is that he founded JMedic, which is an organization that helped build capacity in Uganda, which I still currently work with in addressing medical countermeasure development and giving best possible clinical care to patients with viral hemorrhagic fevers.
Dr. Lawler also served on White House staff in the Homeland Security Council for Biodefense Office under George W. Bush administration, National Security Council Resilience Directorate under the Obama administration.
So I want to have you guys join your hands to welcome these incredible folks to talk about this. And I'll start by passing it over to Joia to set the scene about why this is important, what's at stake, and what have we learned from prior fights.
No matter how many Zoom calls I'm on, we still forget to unmute. Thank you so much for that nice introduction, Nahid, and also just an honor to be here with both Dr. Lawler and Dr. Venkayya. And I think, it is a relatively small world of people that have been working together now for a long time. We're so grateful, Dr. Lawler, for all the work the University of Nebraska did in the Ebola crisis, hosting some of our folks from the Partners in Health side who were at risk of Ebola, who were contacts of Ebola. And I think one of the interesting things about the role that the University of Nebraska played was really being a public resource for a global pandemic. And that was so important to us at the time. And similarly, Dr. Venkayya, both at Gates and also Takeda, these are private companies that have really helped with the global public good. And I think when we think about COVID and COVID vaccine apartheid, it is got to be a proving ground for us for how we live in this globalized world. We are now facing problems that absolutely defy national borders, that absolutely defy the ability of any single government to attack, as well as we may be doing in the United States with vaccines now. We are a globalized world. And I think one of the things that excites me about the center at BU and the work that I've done with Naheed, we really were introduced during the Ebola crisis, is the idea of how do we leverage the resources from academia, from the public sector, from the private sector, to really make the world more fair. And I think there are a number of steps that we've learned from the global AIDS crisis and from the last 40 years of global AIDS, but the 20 years of real full-on global health delivery and implementation. And I would say the lessons are that while the private sector is indeed important, there has to be some sharing of knowledge, and there has to be some way to bring the products of modernity, whether they are new vaccines or therapeutics, into the public domain so that everyone might achieve that. And there's got to be a way to do it and still protect the innovation. And I know Takeda is like at the leading edge of this, and we've done a ton of work with all of you in mental health and cancer, and I think that's really important. And then the other thing is, how do we harness the public sector and academia to bring these things to bear? Because the critique of us as academics, for all of us, whether at Harvard or BU, University of Nebraska, or elsewhere, is that we are in an ivory tower. And we know that that's pretty true, that you can be in a conference and hearing really phenomenal ideas, novel strategies that really are not trickling down. And so I think part of what we need to talk about here is we have to have a strategy other than trickle down. What do we do with intention today in COVID that will allow us to get to equity, and that will allow us to take these fruits of science and modernity and make sure they're available to all? So for me, in the thinking about the AIDS pandemic and how that set us on a path for global health, I think there were really three things. One is to understand that, yes, innovation is critical, and as the system is now, we need to do something to protect and, compensate people for those innovations. And yet we also have to say that there has to be a way to bring this to the larger population, because we know there will be inevitably market failures, that the market alone is not enough. We've seen it with TB drugs, HIV drugs, cancer drugs. And so we've got to figure out what is the plan for equity from the beginning. And a lot of credit to AstraZeneca for working directly with Oxford on the idea that from the beginning of that development of that one particular vaccine, there was an equity plan, the plan of sharing that vaccine with the Serum Institute. And I know Rajeev and Seppi and Gavi and COVAX were very involved in that. And that's the kind of thing we need from the beginning. And yet, if we look at the massive amount of U.S. public investment in the creation of Moderna vaccine, that equity plan was not front and center. And so I think we need to demand that in our own work as researchers, as academics, as advocates. So that's thing one. How do we share that? The second is, how do we take a role as the richest country on earth, as the U.S., in real global diplomacy around health? And I think we saw that the advent of the Global Fund to fight AIDS, TB, and malaria, and later PEPFAR, were transformative in a way, and a real novel, particularly the Global Fund, a really novel way to collaborate across countries, regardless of political affiliation. So North Korea is able to use Global Fund money to treat MDR-TB, and it doesn't have to be a political statement, right? And I think that is a critical piece. And I know, again, COVAX was trying to do that, but I think became, was unfortunately with the way COVID hit so many wealthy countries, it was stunted because people were so scared and stockpiling, their own vaccines. And then the third is really we've got to have a long-term plan for manufacturing medicines and vaccines and commodities throughout the world. It cannot just be from wealthy countries and India and trickling out. I think we need places to make vaccine in Africa, in Latin America, in Asia at scale. And I think if we do these three things, really figuring out an equity plan from the beginning of development, really trying to say that American leadership and our security is tied to this global and public health and funding that. And then the third is really how do we distribute manufacturing? If we can do that, I think that will help us with the other real huge existential threat, which is climate change. Because if we can't collaborate on this, which is really 2 vaccines per person on the planet, it's going to be hard to collaborate on something that is much, much more complicated. And so, I think many of us have learned lessons, met each other along the road of doing things that 20 years ago seemed impossible, like getting antiretrovirals to 27 million people on the planet, like having surgery and CAT scans in, rural Haiti or rural Africa. But there's much more we have to do to make this not about charity, but a really much more significantly distributed scientific and moral project. So, I know that Naheed, we're so excited about your leadership at the center because I know you have both the scientific chops for this and the deep, deep moral conviction. And I think those are the things we really need.
Joia, thank you for that and the kind words. I guess I should have started by introducing myself. I am the founding director of CEID. I realize I didn't start with that. And it is my great pleasure to have both Joia and Rajeev and James talk about this. Rajeev, I'm gonna switch to you because there's one thing that Joia said, which is doing by intention, doing with intention from the beginning. And my understanding is COVAX, part of the reason COVAX was created was because of the failures during H1N1. When it took so long during a pandemic, a then pandemic, to get those vaccines to places that needed it. Could you comment on COVAX, how it came about, how it's doing? Is it doing what it's supposed to? And what do CEPI and some of the other organizations that are supporting it, how are they hoping that it evolves? And what are some of the to Joia's point about manufacturing? And I turn to you for that complexity. The ways to expand access to vaccines seem to be sharing the doses we currently have, supporting the manufacturing of new doses, and then expanding the capacity for manufacturing. What are the challenges along the way, and how can we work on them as a global community?
Wow. Well, thank you, Naheed. That's a lot to cover, but I think it's a natural follow-on to Joia's great introductory remarks. And I also want to congratulate you on the new center and your leadership role. I think you're the perfect person to do this. I have had a chance to work in pandemic planning alongside James in the U.S. And one of the things we learned when thinking about what an influenza pandemic would mean for the US back in the mid-2000s was that there would be huge demand for a vaccine more than anything else. And in fact, at that time, huge investments were made to build out vaccine capacity. It was the one thing that today's technology could do to address a pandemic that was not available back in the 1918 pandemic. And so at the beginning of this pandemic, in the March timeframe of 2020, there was a clear recognition by a number of people that we would have to address equity proactively, because based on the H1N1 experience in 2009 that Joia referenced, we knew that there would not be equitable distribution of limited supplies of vaccine. And so the initial discussions that led to the creation of COVAX they started in the March timeframe of last year. Now, Unfortunately, it took a little while to get COVAX off the ground, open for business, ready to receive resources. And during that time, a number of things happened that then made it difficult for COVAX to execute as intended. But let me just quickly say what COVAX is intended to be. This is a partnership that is led by Gavi, the Vaccine Alliance, as well as CEPI, which is the Coalition for Epidemic Preparedness Innovations that you mentioned earlier, and the World Health Organization, that is intended to do a few things. First of all, it is to pool financial resources across many countries to both procure vaccines for themselves, as well as to contribute resources through traditional development assistance channels to purchase vaccines for low and low middle income countries. Secondly, the goal is that it should spread the risk or pool the risk. And by that, what I mean is in the early days of the pandemic response, many companies started COVID vaccine programs. In fact, over 150 entities started to develop COVID vaccines. Nobody knew who was going to be successful. And if you're sitting in a government and trying to decide which vaccine you're going to purchase, it's really hard to make that decision when you don't know what's actually going to be successful or meet your product attributes. And so by putting money into a facility like COVAX, you could get an assurance that whichever vaccine or vaccines met certain criteria, you would get access to some supply. The third goal, perhaps the most important of COVAX, was that there would be some equity in distribution of limited supplies of vaccine, and that all countries, all boats would be raised in parallel up to a point. Then countries with their own resources could go beyond that threshold and procure more vaccines for themselves. That was the idea. And I personally believe this is exactly the right direction we needed to go. And I think the principles behind COVAX need to live beyond COVID-19 and form the foundation for what we do to prepare for the next pandemic. Now, what got in the way? As I mentioned, there was a timing issue when it was open for business. Another is the political realities of the world, where political leaders are put in office in order to put their population's interest ahead of everything else. National security takes top priority. Economic security is right behind it. Health security is in there. It's actually usually lower on the list for most political leaders, but it's on the list. And so when you're talking about something as devastating a pandemic that threatens national security, economic security, health security, and there is a tool like a vaccine that is becoming available, most political leaders will do everything they can to secure their population's future first before considering others. And that is in fact what we've seen play out in this pandemic. A number of what you could call bilateral deals between governments that had financial resources and companies were made. Limited supply was locked up early in the pandemic, either through deals that were done or through contractual restrictions or even legal restrictions on the ability of companies to export vaccine to other parts of the world. And that led to a difficult situation, which everyone, by the way, anyone who's worked in vaccine development and manufacturing would have told you last year that the supplies were going to be constrained for some time, no matter what. There was no physical way, given the state of the science, the state of manufacturing capacity, to change that situation at the time. And so knowing that you have scarce supply, these additional impediments have created the crisis that we faced in terms of equitable access. Now, the situation we find ourselves in is really what everyone was trying to avoid, where you have perhaps commitments to eventually make vaccine available to the entire world, but a huge temporal divide between the availability of vaccines for the wealthy countries versus the low-income countries and low middle-income countries. Now, the world is waking up to this reality. We have seen a lot of voices in the past few months that have been drawing attention to this. The G7 is happening as we speak, and many are advocating for G7 leaders to step up, because the only way this issue is going to be resolved is if political leaders, the ones that have been making the decisions on allocation of vaccines, make a proactive decision, or actually maybe even a delayed decision to commit to equitable access. The announcement by the Biden administration, which I think James and we will talk more about later, is very welcome in this context. We really do need the largest economies to step up and make the tough choices and show leadership so that others in the G7 and G20 can follow. Now, I want to shift gears and talk about why it's been so difficult to expand capacity, because Joia talked a lot about the lessons of HIV and antiretrovirals, and some of the things we heard early in the HIV crisis, or when antiretrovirals became available, was that these things are really hard to make. You can't expect companies everywhere in the world to be sophisticated enough to do this, and it takes a long time. Well, much of that turned out to not really be the case, because we now see that antiretrovirals are being made in many places in the world and at very low cost and low price. When we look at vaccines, there actually are some really important differences that I think everyone needs to understand, including the most vocal advocates. Vaccine manufacturing is extraordinarily complicated. I got into this about 10 years ago. And I have to say that when I was at the Gates Foundation in the US and in the US government, I did not have an appreciation for just how many things can go wrong in vaccine manufacturing. On top of that, if you're talking about scaling up manufacturing, that usually means partnering with another company that has capacity to transfer your vaccine manufacturing process to them so that they can produce what let's just call a generic vaccine. Now, that is problematic, or it's hard to do. It can be done. It's hard to do because of two issues. One is that we can't characterize vaccines on a chemical structure basis the same way we can drugs, like antiretrovirals. For an antiretroviral, you show me the chemical structure and you're 80% of the way to convincing me that you've got the same product as the originator. That is absolutely not the case in vaccines. They're very complex biologics. The second issue is that we don't usually understand what exactly you need in the way of an immune response to protect a person from future infection for prophylactic infectious disease vaccines. So the product is hard to characterize. We don't really understand what you need about the immune response, at least initially in the early days. And so it comes down to the process being the thing you have to replicate. And when I say replicate the process between the originator and a new company, I mean everything about the process: the raw materials, the seed viruses, the cell substrate that's used for cell culture, the exact equipment and components that are used throughout the process, the training, the procedures, the analytical tools, the assays. All of that has to be replicated perfectly. And that takes time. Now, here's the challenge. If you're in AstraZeneca, Novavax, J&J, all those companies have committed to doing more tech transfers than any company has ever tried to do in history. You're taking the same small team that knows the process, that is spending their day job manufacturing vaccine, and you're spreading them across all of these partnerships to make these tech transfers to make sure they go well. The more you do, the more risk you take on in every single one of those partnerships. You also need to have a receiving partner that has experience. And some of the suggestions that have been made recently about scaling up and having companies that have never manufactured vaccines for the global market before, it's just not going to work. I mean, even if you could make the tech transfer happen, the WHO and regulators would never sign up to this, because there's no way that you could demonstrate the consistency of the product and the process in a time frame needed to make a difference in the pandemic. So these are some of the challenges that we face. On top of that, we of course have a significant raw materials supply constraint that is affecting the entire industry. We're focused now on vaccines, but I can tell you the same filters and components used in manufacturing of vaccines are also used in other biologics. And across the entire industry, this pressure is being felt, and we potentially are going to be seeing delays in non-vaccine products as a result of it. So before I close and turn it over to you and James, let me just say that there are some great learnings from this experience that I think we can take into our preparedness for the next pandemic, and I think reasons for hope. First of all, I think COVAX is directionally exactly what we need to be doing. I think there are some great lessons from the Operation Warp Speed efforts in the US that can be globalized. So we benefit from the learnings there. I absolutely think that we need to commit to establishing distributed vaccine manufacturing in low and middle income countries that aren't currently manufacturing vaccines. I don't mean every country. That's probably not rational. But at least on a regional basis, particularly in the African region, we need to commit to establishing the talent pool, the supply chains, the regulatory competence, everything necessary to have an ecosystem that allows vaccine manufacturing to happen. And here I think that the mRNA technology platform represents a great gateway to get into vaccine manufacturing, because it's less complex, less risky than more traditional approaches to manufacturing. And the last word of hope that I'll leave us with is that, again, the US donation of 500 million doses of the Pfizer vaccine between this year and next, I think is I won't say it's a great gesture. It's a great decision. We need a lot more of that. And I'm hoping that others will take, at the G7 and G20, will take the lead of the US and Japan and the UK and others that have taken significant steps to help us to achieve this goal of global equitable access.
Thank you, Rajeev. I'm going to come back to that whole scaling out versus scaling up, because we actually did have a question among the audience before the event about this as well, about what that move forward is. So this is an interesting quandary, right? We know that vaccines, next time this happens, the lessons from this time show, as they have shown in H1N1, that speed matters and coverage matters. And so how do we, coverage is important. We build that in with intention. And how do we work on that speed, James? Because, you know, as Rajeev started with, it's always going to go up against national political priorities and national security issues. And you've sort of seen this play out in a couple of ways, in the way that both the high-income countries have, because they have higher purchasing power, take majority of the available doses. But then you've also seen, in many instances, vaccine diplomacy, and particularly vaccine diplomacy to influence geopolitics, play a role. We've seen that President Biden, now I've heard him say this twice, including today, through his address of the donation that the U.S. will be doing in terms of purchasing, about how China and Russia are potentially using that vaccine donations as a way to establish geopolitical influence. So let me start by saying this: how do we balance those two things? You know, and how do we get beyond that vaccine diplomacy issues with geopolitics that are currently exist in the current pandemic? And then why, you know, from your perch of having worked on pandemic preparedness, similar to Rajeev, similar to Joia, how do we, looking forward, why is this important for the next one? And how do we put down the roots today to make sure that resilience gets built before the next one happens?
Well, thanks, Naheed. And first of all, let me start out by congratulating you as well on the new center. Certainly a great step forward for really the nation and the world, and well deserved on your part. So. Interesting questions that you raise, and certainly things that we often thought about in the pandemic preparedness and response teams. That you can blame Rajeev for bringing me into that. I think in one of the few gross lapses in judgment of Rajeev's career, bringing me into the Homeland Security Council team was one. But despite what Rajeev will tell you, I may have learned one or two things during my time there and back with NSC during H1N1. And I think one of those things that I learned is never count on a group of politicians to make a decision based on ethical or moral principles. And if that's where you're pinning your hopes, that's a lost cause. And so you really need to look at this through the lens of national security and why this is so critical to the US from a national security perspective. It is critical for us to continue pushing our administration, our government, and the people of the US to recognize how important our response will continue to be. I was on a webinar with Richard Hatchett earlier today, and he was commenting on the fact that this pandemic is nowhere near over. And I think in the US, we have the perspective that we're free and clear, but clearly the rest of the world is going to suffer tremendously and for an extended period of time. And I think now, unfortunately, many are realizing that the myths of the Indian miracle and the African miracle and all of that was just that. It was myth. And now we're seeing, unfortunately, the impact of the pandemic on low and middle income countries. And it's devastating, and it's going to continue to be devastating, and we won't know the full impact for many years. But from our perspective, it's in our enlightened self-interest to do something about that now, and also to prepare for the next pandemic, which certainly will come. and probably will come much earlier than we all suspect or hope, for many of the reasons we've talked about. And the first principle I think that's important to embrace is this idea of defense in depth. We're not safe as a nation when there is a pandemic virus circulating anywhere in the world. And that, I think, has been demonstrated in 2014 with Ebola. It's been demonstrated, obviously, with the COVID-19 pandemic, and it will continue to be an important principle that we have to take to heart. We cannot simply build a wall around the US and expect that that's going to keep anything out, particularly virus. And the idea that we have to extend our actions to international partners to be able to collectively find and suppress these outbreaks early is something that we need to take to heart. The second thing that is a national security imperative for us is to promote stability around the world. And I think, unfortunately, we're going to see in many low and middle income countries in the coming months and even years, as they continue to suffer from the pandemic, we will see significant impact on society and economy, as Naheed, I think you pointed out, but also we'll see significant impact in governments. When people can't get their next meal, when they have no confidence that their government is doing the steps to protect them and their families, that's when you run into situations of failed states. When people can't have access to food, people can't have access to resources. And obviously, we know that those environments are the environments that promote instability. That is where terrorists and other bad actors come into play, and creating those vacuums by allowing those events to proceed unchecked ultimately works against us. And again, I think that's a lesson we probably should have learned a long time ago. But the pandemic is going to have a huge impact directly on health, but also indirectly, as you pointed out, in exacerbating poverty, hunger, exacerbating other disease control efforts or worsening those efforts, impacting education that could have decades-long repercussions in many of these countries. And if we're not there to help stem that tide and to preserve stability, we will be the ones who ultimately suffer 10 or 20 years down the line. The second principle there is in developing better global allies in our security actions and also in our economic partnerships. We have, in my experience, one of the more successful international outreach programs the US has ever engaged in was PEPFAR. And I still, when I'm working in Africa, often have conversations with colleagues and not only people in the medical or research community, but people out on the street in general who, once they see you're an American, will often come up and say, it's amazing what the US did for us with PEPFAR. We had, this whole street, every other merchant was a coffin maker back when, before PEPFAR started, in the early 2000s. And now, we've gotten our community back again. That type of lasting impression is hugely impactful. And that type of goodwill and alliance is something that we should not overlook and should not minimize. The last security imperative is, I think, in terms of global trade. We are now an interconnected world that is completely dependent on the functioning of that international global supply chain. Again, I think we witnessed that very acutely during the pandemic, when all of a sudden lots of things became very difficult to come by, from N95 respirators to toilet paper. And that's because of the global interconnectedness that we rely on to live our day-to-day lives. And that's true across the world. And unless we continue to cultivate those relationships and build and strengthen those global trading partners, we leave ourselves vulnerable. And so for all of these reasons, continuing to push for additional actions in vaccine equity are really important. And while I agree with everyone that the recent announcement by the administration is really important, let's be honest, we're giving out of our excess, right? It's not as if we're making a sacrifice to help provide vaccine to everybody else in the world.
Yeah.
We've gone now 6 months, more than 6 months, where we've had vaccine available, and we've really done nothing to help the rest of the world, particularly healthcare workers across the globe. And we have, tens of millions, hundreds of millions of doses still of vaccine now sitting in warehouses in the US that are going unused. And so as welcome as that announcement is, it is not nearly enough, and we need to do more. This isn't the first time that we've struggled with the concept of vaccine donation. And many of you may remember in 2009 during the H1 pandemic, eventually we were able to get the US government to commit 10% of our flu vaccine to the international community in September of 2009. And in large part, that was actually due to the efforts of Richard Hatchett, who was there at NSC with us at that time, who really pushed that, pushed the administration and pushed many people in the government who were quite reticent to give up that precious supply to be able to do that. So it can happen, but it takes a tremendous amount of political will and effort. I think another lesson from 2009, however, is that even though that commitment was made and the global community committed, I think, around 200 million doses of influenza vaccine, only 60 million doses ended up being distributed to countries that needed it at the time. And that goes to show the importance of the last mile in enabling vaccine distribution and utilization. It's not enough that we build production capacity. It's not enough that we have vaccine sitting on the docks in port cities, which is what happened in 2009. You have to develop the systems to get that vaccine from the warehouse in the capital city out into the arms of the people who actually need it. And that is a critical component of what needs to be built. And so that long-term vaccine equity problem is multifactorial. It is not just in terms of production. It's not just getting the IP into the hands of people who can make vaccine. It's a soup to nuts problem of being able to eventually get that vaccine into the arms of people who need it. And I would also point out that it's not just vaccines where we have to make progress. We have tremendous inequity in our ability to provide diagnostic technology for most of the world. So one of the reasons why we've had very limited visibility into COVID-19 in many of these countries is because they simply don't have the diagnostic capacity to be able to make a definitive laboratory diagnosis. And that's been a huge handicap, I think, for all of us, understanding how extensive the pandemic has been, and also understanding where new variants are emerging. And therapeutics is another place where we need to make significant progress in enabling folks to be able to treat. We've had problems implementing therapeutics in the US. We have monoclonal antibody products, which are by far the best therapeutic product that we've developed for COVID-19. We still can't get physicians in the US to administer those correctly to the people who need them. Imagine the challenge of trying to do that on a global scale, but that's exactly what we need to do. We need to be able to provide the type of capacity to make those therapeutics, distribute them rapidly into a health system that is postured to be able to identify the people that need them and deliver those therapeutics effectively. So I think all of these things are important, but I think the last point to make is that these systems can't be built in the middle of an emergency as we're trying to do now. Again, that's a strategy that is proven ineffective again and again. If we're going to be able to do this in the long term, we have to make the commitment to be on the ground working with these partner countries in peacetime, so to speak, between pandemics, between emergencies, to be able to carry out the response that we need when we finally are facing a crisis. And so I'll stop there, Naheed.
Thank you. And I want to pick up a thread that a question, I'll take the imperative being the moderator to ask the first question. The point that you made about the India miracle or the Africa miracle, I want to just expand on what you're saying, which is that because we didn't see the deaths, and we didn't see the deaths partly because maybe we don't have a handle on how much of the excess mortality is from COVID versus not, because we don't have those diagnostics in place. But beyond that, there does seem to be a shift, right? You're seeing more transmissible variants that are affecting younger populations. You're seeing all of a sudden surges in many of the regions that all of us work in. And timing seems to matter. This 500 million doses, only 200 million of that is during 2021. What needs to happen in the next 6 months to meet? So COVAX, I think, I believe Rajeev did mention that 2 billion is what would be needed, doses would be needed to hit all the healthcare workers and most of the vulnerable populations by the end of the year. What needs to happen in the next 6 months? Because it's not just the coverage, it's also the timing. I'll start out with you, Joia, and then go down the line.
Yeah, I just don't think we can just operate on the business as usual. I mean, we are in a war. This should be a wartime preparation. This has to be massive collaboration. And honestly, I think we have to think not about what can we do with 1 million doses, half a billion doses, but actually, how do we get to 10 billion doses, right? That has to be the goal. And if that's not the goal today, then we're never going to get there piecemeal. I mean, I just don't think it's reasonable because the variants, the race with the variants, and I want to see the G7 and the countries that are affected sit down at a table and say, okay, we need 10 billion doses. How are we going to get there? And I just don't, unless we do that, we're not going to get out of this in 5 years. We cannot piecemeal our way out of this one. And then the second thing, I'm going to just take the liberty because there was another two questions from Lachlan Faro in the chat about, the idea that politicians are never going to do something out of the moral imperative. I kind of agree with that, with what James is saying, but to me, human rights is a dialectic. It's a dialectic between governments and civil society. And it's we and civil society who have to have that moral compass to force the politicians to do something. And how do we do that? We do that with our vote. We do that with popular protest. We do that with writing, with raising our voices. And so I think using the moral necessity to change the political calculus, that's how activism works. So I agree that the politicians may not act on a moral basis, but they will certainly act if people stand up. And so that is the role of civil society and youth groups, as you queried, Lachlan and others. And I think that's where we have to just say that, giving our little excess, our excess is going to expire before we even give it away. We just heard we might be able to get some doses for Haiti that are expiring in 10 days. So, that is not a strategy. Charity is not a strategy for a global pandemic that is completely derailing people's lives and causing impending famine. And so I just really want us to fight for the full equity now and to bring people to the table now, and civil society is going to need to push that, in my opinion.
Rajeev, what would you do? We wave the wand for the next 6 months. Well, semi-realistically, no magic wand.
Sorry, I'm not realistic.
No, you are realistic.
I know you're not saying that, but I also know it's
Yeah. I think what you're saying is actually the most realistic strategy. But what would you do, Rajeev, within what is possible, and including the expanded dimensions that Joia has also talked about in terms of influencing government?
Look, I first of all, I want to endorse what Joia is saying about the outrage, about the urgency to address this issue. I mean, one of the things that I wish we would have seen from the advocacy community, honestly, is more advocacy on this issue last year. You know, if you look at what was being said for much of 2020, we didn't hear much about equitable access. I posted something about equitable access in April of last year, and I got 1 like. Now, I didn't have that many followers at the time, but my point is that, and this is a bit tongue in cheek, is that until Europe and US got doses, we didn't see a lot of noise made about this equity issue. Now, having said that, I do think that we need to pull out all the stops, and we need a Marshall Plan-like approach to this, where G7, G20 countries get together and throw all the resources necessary at this to get it done. The IMF has put out a $50 billion proposal, which that's a reasonable price tag. I mean, that's the kind of resource commitment that we need given the magnitude of the problem. Now, there are some constraints that we need to be realistic about. You know, there is only so much upstream supply available. We need to maximize that. There is only so much manufacturing capacity available. Now, we can expand that, and we should do everything we can to put in additional lines, build new facilities to the extent possible. One area that people don't spend a lot of time talking about is what I mentioned earlier, which is the risk associated with multiple tech transfers from a given originator company. You can only do so many of those, but we can bring in more experts to help with that. So all of these things can be facilitated by government support. And obviously we need to eliminate export controls on raw materials and that kind of thing. There is a projection out there that is risk adjusted that by the end of this year, we could have more than 10 billion doses of vaccine. I'm skeptical about that. I have to say.
Is that the one from Public Citizen, Rajeev?
It's from a firm called Airfinity.
Okay.
What they've done is they've looked at all the companies' publicly stated projections. They've risk adjusted them down. I think they probably need to risk adjust them down further, but that's what they're projecting toward the end of 21. So this problem will get solved. Whether it gets solved in the next 6 months or 12 or 18 months, that's really hard to predict because of all the risk embedded in manufacturing. But it will get solved eventually. The problem is the temporal inequity is really what is completely unacceptable here. And I completely agree that the 500 million doses in June of 2020 is pretty late, and it's not a lot relative to the global need. I wish we would have seen this much earlier. I do think that there is a reasonable debate to be had about whether young children in the US should be getting vaccine, or people should be getting their 3rd booster dose in the US before healthcare workers or vulnerable populations in other parts of the world are getting their 1st dose of vaccine. I mean, these are the questions that
Yes. Yep.
James, same to you. 6 months. What needs to happen?
So I think there's a couple of things. First of all, as Joia and Rajeev pointed out, we need to pull out all the stops in terms of every tool that we have to influence change, including advocacy, including policy groups, including us in academia, and obviously industry and governments need to step up to increase vaccine supply. And I think, as Joia correctly pointed out, the ultimate goal has to be vaccinating 7 billion people, right? That's our goal. But the reality is that's not going to happen in 6 months, right? That's probably not even going to happen in a year or 18 months, given the pace where things are going now. And again, it's not just producing enough vaccine, it's then being able to distribute that vaccine effectively and get it into the arms of the people who need it. So we need to start and redouble our efforts over the next 6 months to make that happen. The other thing we need to do is focus on the other tools that we have at our disposal that enable us to control community transmission and prevent what happened in India from happening again. We have tools that work, right? Non-pharmaceutical interventions have been used all over the world, and not only in high-income countries. I can point out there are some countries in sub-Saharan Africa that have used suites of non-pharmaceutical interventions very effectively. And what we can do as more resourced countries is to provide additional tools for those countries to be able to employ them intelligently and effectively, so that it is not this, I think, false dichotomy that people have drawn up. It's either lockdown or you're completely open. There are intelligent interventions in those non-pharmaceutical interventions that can be used. even just supplying ample supplies of face masks to many of these countries, which that's a resource that's much easier to scale up and distribute effectively than our vaccines. Those are things that we can achieve in the next 6 months that would make a big impact.
Yeah, I'm going to comment on a couple of things. And Rajeev, I think you have a quick comment, but I wanted to point out to Sandeep Shreda's comment that it's about timing, because what we saw was because India was affected, Serum Institute of India stopped exporting, and there was about a 200 million dose lag within COVAX, which affected second doses for many countries. You're hearing that from Kenya, you're seeing that from Honduras. Nepal is seeing that, and that timing is definitely an issue. Go ahead, Rajeev. I think you had a question on the 6 month, or yeah, a response.
I left out one important strategy, which is that dose stretching. So looking at whether the current dosing that we're using is necessary, or can we reduce the size of the dose? And I know that this is being looked at Moderna. But if you can, say halve the dose, cut it in half, then that's obviously twice as many people that immunize. And also there is very promising data that if you've been exposed to COVID in the past and you get your first dose, that you're going to have a response that appears to be similar to what you'd have after 2 doses of a vaccine for a same person. So these are dose or supply stretching strategies also need to be pursued aggressively.
Let me ask a question. We're edging towards the end of the hour, but there's a question that was handed in early before the event, but also something that echoes a question that's in from Martha Coe in the Q&A, which says, I think coming to the same point of how do you get companies whose main goal is profit to work on equitable distribution. And then Martha also talks about the idea of how do we create that demand? Those seem to be tied in. How do we work on the self-interest of the companies while also ensuring equitable distribution? So open it up to any of you that want to comment on that, creating market demand, and then ensuring that after creating the market demand, that we're going to have equitable distribution.
Mm-hmm.
Well, I think in this case, you don't need to create a market.
Yeah.
Everybody knew a year ago that or a year and a half, at the beginning of this, there's going to be a huge market for a vaccine. Yeah. So that's specific to COVID. In other areas, it is a big problem. But here, the demand wasn't the problem. The issue is how can you lock up supply for low and middle income countries. And here, I wish that COVAX had been resourced and open for business.
Yes.
So that they could have reserved supply before it was reserved by others.
And even, I think one of the struggles with COVAX is because it's been all voluntary. I know that Canada, for example, committed to COVAX, but then went and got their, decided they want to take the vaccines back from COVAX. So I think putting enough money in initially to assure, because the problem with public health is the supply demand doesn't work. In my opinion, that because poor countries and poor people just cannot use their money as a demand factor, there's going to be market failures. And so we've got to think of equity and the supply that we need, and then backfill that with the money and the resources and the strategy. And that's, that to me is the lesson for, how the Ebola vaccine was used in the DRC outbreak, for example, or how antiretrovirals were used, or creating the stockpile of cholera vaccine at WHO after the outbreak in Haiti. I think you've got to sort of make a much more planful thing, because if we just say, well, yeah, Yemen, if they really want the cholera vaccine, they'll pay for it. Of course not. Right. And so I just feel like even the language we use of supply demand just doesn't work when the market failure is built in to the equity proposition. And so I just think we've got to have something of a pandemic fund, like we have the global fund. We've got to have stockpiles. We've got to have massive manufacturing. And as James was saying, now, for the next pandemic, we've got to do everything possible for this pandemic, but we also have to be planning for the next pandemic.
Either one of you want to reflect on that? All right, hard question, a tough one, which we don't have a lot of time to cover. Disinformation. none of us expected the level of disinformation that was going to exist at the very beginning of this pandemic. And in this last minute, I know we're not going to solve the problem, but vaccine disinformation in particular and misinformation has played a big role. Any lessons we've learned that could help us protect ourselves against vaccine disinformation and misinformation in the future from the experience so far in COVID?
Well, okay, I'll just say quickly, I think social media has proven to be a double-edged sword. I mean, there are some positive things about it, but in this pandemic, to me, it's an open question as to whether it added value or net damaged our response more than anything else. And I would also say that in the U.S., the failure of leadership to get behind the science consistently amplified the problem.
Yeah, I think we underappreciated the psychological power that social media has, and how, when it's used purposefully and nefariously, it can be a huge weapon. And we clearly were not prepared for that. And that's a hard problem, certainly in 10 seconds to describe how we answer it. But I don't know how you counteract that, to be honest.
Open question, and that's what CEID is about, is continuing to work on those open questions. I want to give a huge round of applause and a big thank you to Drs. Mukherjee, Lawler, and Venkayya for joining us for this inaugural event for CEID. Thank you guys for what you do in your everyday, and thank you for your commitment to this global goal and bringing this pandemic to an end. And thank you to everybody else who's joined so far in the event. Thank you.
Thank you, Naheed. Bye. Bye, everyone.